Hey everyone, I'm Talia Browdy and I did my case presentation on ectopic pregnancy. The typical patient presentation, here we have a 35-year-old female who comes to the health facility with a history of tubal surgeries or operations on her fallopian tubes. She's confirmed a positive pregnancy test and she knows she's now in her first trimester. She's now experiencing vaginal bleeding as well as abdominal pain and tenderness. Her last menstrual period was about 4 months ago. Etiology of ectopic pregnancy. So an ectopic pregnancy is when a fertilized egg implants itself anywhere that is not the uterus, so anywhere besides where it should be, pretty much. Over 95% of the time this happens in the fallopian tubes, but it can also occur in the ovary. The fertilized egg can implant itself to the cervix, but the vast majority of the time it does happen in the fallopian tubes. What happens is these tubes are unable to stretch to accommodate the embryo as it grows. So as the embryo gets bigger, so does the chances for maternal bleeding. So ectopic pregnancies are a high-risk condition that happen in about 2% of all pregnancies. So they're rare, but they do occur. There is a potential for severe pain, bleeding, or rupturing of a fallopian tube, which allows it to be classified as high risk, although this generally happens once an ectopic pregnancy ruptures. In 1878, Otto Spielberg created this Spielberg criteria, which just aided in the diagnostic process for these ectopic pregnancies, as they were incredibly difficult to diagnose at first. So like I said before, ruptured ectopic pregnancies are definitely more high risk than the unruptured ectopic pregnancies, which do have a low mortality rate. However, once these ectopic pregnancies rupture, they are the number one cause of first trimester pregnancy-related deaths, making up about 10% of all maternal deaths, which is a very significant number. And the hemorrhaging caused by this rupturing of the fallopian tube is what leads to the fatalities. Luckily, since the invention of transvaginal ultrasonography and beta-HCG testing, this incidence of rupture and overall mortality has lowered. There are a number of risk factors for ectopic pregnancy. These top two in bold are definitely the most significant. So having undergone a previous tubal surgery or having had an ectopic pregnancy in the past will amp up the risk. Now, all these risk factors are super important and helpful to medical staff in assessing a woman who might be coming into the facility with an ectopic pregnancy, as it helps to assess her level of risk and get her treated in the best way, the fastest. So previous infections of the reproductive system, any history of infertility, previous IUD use, being of a 35 and up age, all of these are helpful for medical staff to look at when assessing a patient. So now let's talk about the pathophysiology of ectopic pregnancy. So when an egg gets fertilized, it moves down the fallopian tube towards the uterus. But if this tube is blocked off from infection or scar tissue at any point, the zygote will get stuck and begin to develop inside the fallopian tube. Like I said before, this type of fallopian tube obstruction or distortion are thought to be the leading causes, hence those two most significant risk factors of a prior surgery to the tubes or a prior ectopic pregnancy. And also, like I said before, 97% of ectopic pregnancies occur in the fallopian tube, but it can be experienced elsewhere, which will vastly vary a woman's experience and the pathophysiology of what's happening to her, as well as whether it is unruptured or has become a ruptured ectopic pregnancy. So now let's look at the clinical presentation of ectopic pregnancy and what one would expect to see in the clinical examination. So vaginal bleeding, pelvic pain, and a palpable adnexal mass are absolutely the three key things that are to be looked for in a clinical presentation. Now, if any significant abdominal tenderness or hypotension is seen in this examination, that's when it's time to consider maybe this ectopic pregnancy has ruptured. Here is a visual diagram just to sort of show the disparities of what these ectopic pregnancies look like compared to a normal intrauterine pregnancy. Obviously, in the diagram on the left, we see the embryo is normally implanted towards the left side of the uterus, And in this diagram on the right, we see a variety of different places in which this fertilized egg can implant itself and potentially begin to cause serious problems. And the pathophysiology of ectopic pregnancies are so significant because this implantation of a fertilized egg anywhere besides the uterus's lining can really lead to morbidity and jeopardize a woman's fertility in the future, meaning there are really long-lasting effects of these pregnancies. And diagnostic testing is absolutely essential in determining the proper treatment method, as there are a couple of different treatment routes that can be taken with ectopic pregnancies. And here's just another diagram showing the likelihood of an ectopic pregnancy to occur in these different places around the female reproductive tract. There are 3 commonly presenting major symptoms of ectopic pregnancies, and these don't always coexist. In fact, only about half of patients present with all 3 of them. Amenorrhea is a missed period, so absence of a menstrual period, and even if the fertilized egg has implanted itself outside of the uterus, all pregnant women produce this HCG, which will stop menstruation, so that is one symptom. Vaginal bleeding is another symptom, which can start immediately upon implantation in the tube or a bit later on, but this uterine lining breaks down due to the lack of progesterone, which is necessary to keep it intact. And as said before, ruptured ectopic pregnancies do often bleed severely, so this is absolutely a major symptom of that. Abdominal pain and tenderness is our 3rd major symptom, which can range from moderate to severe and be either all over the abdomen or just on one side, which is often the side with the impacted tube or area where the fertilized egg is implanted itself. Patients may also present with an adnexal mass. In diagnosing suspected ectopic pregnancies, assessing the patient's presentation, history, and risk factors is going to be a super critical first step. Next, the clinical exam must be performed just to determine their risk of ectopic pregnancy, where they're at with it, and what treatments need to be done and when. If a patient is found in a state of shock, they will often be given surgical intervention of some sort. If a patient is stable, they will be placed in a risk group and given the appropriate treatment. Transvaginal ultrasonography and serial quantitative beta-HCG measurements are approximately 96% sensitive and 97% specific in diagnoses, meaning these are really fantastic diagnosing measurement tools. Some differential diagnoses of ectopic pregnancies can be miscarriage, it can look like ovarian torsion, it can be confused for pelvic inflammatory disorder, PID, or even a tubo-ovarian abscess. So for our diagnostic testing measures, we'll always be started with a urine pregnancy test just to confirm that the woman is pregnant. Then ultrasonography and beta-HCG measurement will be used together to give the most accurate diagnosis. So ultrasonography is the diagnostic test of choice simply because of how specific and sensitive it is, but it must be used simultaneously with the beta-HCG testing just to assess those levels of increase and make sure they're normal in comparison to an intrauterine pregnancy. Diagnostic coverage is only used in specific circumstances, so when beta-HCG levels are falling, or if they're elevated but there's no detection of an intrauterine pregnancy, will this diagnostic testing measure be used. There are 3 potential courses of treatment for ectopic pregnancies, as they can all be so different, but expectant management, medical treatment, and surgery are used frequently. Expectant management is used on an ideal candidate with beta-HCG levels of under 1,000 and ideally declining, with no fetal heartbeat, and they're willing to comply with follow-up instructions. Medical treatment is around 90% effective and is given in the form of methotrexate. It can be given in single or multiple doses, but the more doses a patient is given, the more side effects they will have to deal with, and also the more successful it is. Surgery is only used on hemodynamically unstable patients or patients with suspected ruptured ectopic pregnancies. And here are my references I used in this project. Thank you.